Good afternoon, everyone. Thanks for joining us. We're going to give it another minute here to fill up the room. Good afternoon, everyone. Thanks for joining us. We'll give it another minute or so to fill the room here. Good afternoon, everyone. Thanks again for joining us. We'll give it about 30 more seconds to fill the room. All right, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the new VWD Guidelines in Management. My name is Brett Spitali, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you'd like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our presenter after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, May 28th. I'm joined today by Dr. Veronica Flood from the Medical School of Wisconsin. Thank you for taking the time to join us today, Veronica, and I will now turn it over to you to get us started.
Thank you so much. I really appreciate the opportunity to speak today. I am excited to be presenting some details on the new management guidelines for von Willebrand disease. And we have the beautiful new NHF slide deck with their mission statement. And then I also want to note specifically, I have no financial conflicts of interest to disclose. I did serve as the clinical chair of the ASH, ISTH, NHF, WFH guidelines on the management of von Willebrand disease, which you could argue is an intellectual conflict of interest. So I may be a little biased about the guidelines, but hopefully I will be good at noting where things still need more work to be done in some of these areas. All right, so what I'm going to be focusing on today is the new guidelines on the management of von Willebrand disease. These were officially published this winter in January 2021 in Blood Advances, and this is available, I am assured, for free anywhere you live. So you should be able to download these, but if you have any trouble with it, please let me know if you want your own copy. I'm going to be going over the highlights, but there's obviously a lot more detail in this many-page document. The other reason I want to spend a moment on this slide is because the chairs have been public for a while, but the publication this winter marked the first time we were able to unveil the people that really did most of this work. So I want to acknowledge everybody listed here, many of whom are members of the von Willebrand disease community and are fantastic patient representatives who really did a phenomenal job representing other viewpoints on the guidelines. So these were all the people that were involved, and many people who did way more work than I did. I just get to sit up here and discuss it with you all. All right, so I know that Dr. Sidonio presented the diagnosis guidelines a couple weeks ago, but just in case there are people joining just for the management side of things, I wanted to outline a little bit of the principles around the guidelines. So the goal is a commitment to improving the quality of life for patients with von Willebrand disease. And the idea is that sharing the expertise and resources ensures the quality, credibility, and wide dissemination and implementation of the guidelines. Patient input was critical to this effort and obtained in several areas. Through membership on the panels, we had 3 patient representatives on the management panel. There was a stakeholder survey that was published last year in Hemophilia, where patients rated the topics that were most important to them. And there was an open public comment period where everyone could put in their comments on the guidelines. And thank you to everyone who filled out the survey, because that was what really drove the topics that were chosen for the guidelines. The objectives are to facilitate clinical decision-making regarding the diagnosis and management of von Willebrand disease, to contribute to better health outcomes, quality of life, and health equity, to increase access to appropriate diagnostic testing and therapeutic options. And some of these were designed specifically to allow us to go to insurance companies and say, look, this is in the guidelines, you need to cover this. Identify research priorities, of which there are unfortunately a lot, and guide healthcare providers, payers, patients, and other stakeholders as to priority focus areas in von Willebrand disease. So I'm going to go through the specific recommendations. I do want to note some interesting language that you'll see as you read these. There are strong recommendations and there are conditional recommendations. The diagnosis guideline does have a couple of strong recommendations. The language there is that the panel recommends something be done, which you interpret as, for patients, most individuals would want that intervention, whatever it is. And from the clinician side, clinicians would be thinking most individuals should then receive that intervention. The management guidelines, primarily due to a lack of evidence, are conditional, which is worded as the panel suggests something. And what this means for patients is that we think the majority of patients would want this intervention, but many would not. And for clinicians, different choices will be appropriate for different patients depending on their values and preferences. And here, it's an important concept called shared decision making, which I think we'll be emphasizing over and over again. And I want to specifically thank NHF for taking on the huge project of making some actual shared decision making aids for patients and their physicians in these areas where the evidence doesn't really say you should absolutely do one thing, so there's a lot of room for how individual people's values contribute to what they might want to do. All right, so I want to start with a patient case, and I've tried to scatter some cases throughout this presentation. The first case is a 21-year-old female with heavy menstrual bleeding. She reports that her periods last about 8 days. They occur approximately once per month. And on heavy days, she changes her protection every 1 to 2 hours. A von Willebrand screen is done, and her von Willebrand factor antigen is 18, normal being over 50, and her activity is 20. So she receives a diagnosis of type 1 von Willebrand disease. What are the best options for treating her periods? So we do have a recommendation in the guideline regarding management of heavy menstrual bleeding. And this was a topic that received a very high priority in the scoping survey. The way the recommendation is worded, it states that the panel suggests, meaning it's a conditional recommendation, using either hormonal therapy, either combined hormonal contraception or a levonorgestrel releasing IUD, like the Mirena, or using tranexamic acid over desmopressin to treat women with von Willebrand disease with heavy menstrual bleeding who do not wish to conceive at that time. And this recommendation, the either or, was based a lot on the fact that while quality of life may be the most improved if you're using hormonal contraception, personal values and beliefs may make use of hormones less acceptable to some women. And the panel judged that tranexamic acid had the least harmful undesirable effects, especially when compared to desmopressin. So that's where that came from. I'm going to show a couple slides of evidence for this. And I think if there's any, I know this is potentially a mixed audience. So if there's any patients with von Willebrand disease that are listening to this, you probably don't need this slide, but for the providers out there, this is a study that looked at the number of women, persons who menstruate with von Willebrand disease, who had certain effects of heavy menstrual bleeding. And you can see that over half, for the most part, experienced significant side effects, including flooding, affected family life, affected vacation, leisure activities, anxiety, prevented work, prevented housework. I mean, I would be happy for a preventing housework, get out of jail card, but I think this really shows the impact that heavy menstrual bleeding has on persons who menstruate who have von Willebrand disease and impaired quality of life. There is actually some very nice data from Peter Kowides et al. That looked at tranexamic acid versus desmopressin for heavy menstrual bleeding. And the way they had designed this study, you could either get desmopressin first and then tranexamic acid, which is the solid line, or tranexamic acid first and then desmopressin, which is the dotted line. And I think if you focus on the dotted line, you can see the one that starts dotted. Interestingly, the women in this study had an improvement in their bleeding. And then when they switched to desmopressin, their bleeding got worse. So this is where some of the evidence for tranexamic acid over desmopressin comes from. I do want to pause though and say that these are still recommendations that are conditional, meaning that an individual person may have reasons for wanting one particular treatment over another. This does not mean you can't use desmopressin for heavy menstrual bleeding. It just means on average, we expect more people would respond to tranexamic acid than would to desmopressin. So there's a lot of room for personal preferences regarding side effect profile, ease of administration, et cetera, especially with regards to this heavy menstrual bleeding treatment question. And I do want to note that intranasal desmopressin, Stimate, has been a mainstay of von Willebrand disease treatment. And while we still have IV desmopressin available, the intranasal form has been recalled by the manufacturer. The typical other forms of intranasal desmopressin are not concentrated enough to use for von Willebrand disease, although there may be some specialty pharmacies willing to try to make something equivalent to Stimate. They're currently, the latest we've heard is they're anticipating it back on the market in 2023 with a question mark. So this kind of happened while these were being published. I guess fortunately we weren't recommending desmopressin as first line because that is not currently readily available. And I think IV desmopressin, especially if you're using it to treat heavy menstrual bleeding, would be extraordinarily inconvenient. This is also not to say that some women might be wanting to use factor for their periods, and we'll actually cover that when we talk about prophylaxis. All right, this is my data slide on the randomized trial of hormone therapy versus antifibrinolytic therapy. And this is literally all the data that there is on that, which is to say we have no data. A lot of this is individual studies of one treatment or the other treatment. So there's really no evidence to recommend one or the other. So again, we're back to there is a lot of room for patient preference in this regard. And treatment is important. This is one study that demonstrates how this particular treatment trial was using the Mirena IUD and how much it improved patients' iron stores when they were treated. We know that many women with von Willebrand disease are at high risk of iron deficiency. So there's definitely reasons that you might want to consider treating heavy menstrual bleeding. The data on exactly what to do are a little bit limited. All right. There is a co-recommendation that goes along with that first one, which says the panel suggests using tranexamic acid over desmopressin to treat women with von Willebrand disease with heavy menstrual bleeding who wish to conceive. Again, another conditional recommendation. And this is because tranexamic acid was judged to be the least harmful compared to desmopressin, possibly a little bit greater efficacy. But if you have somebody who wishes to conceive, they are not going to want to be taking hormonal therapy. So the combined oral contraceptives, the IUD, is out for somebody that wishes to conceive. Again, factor would still be an option. It's just the majority of women with von Willebrand disease are going to be type 1 and may not necessarily need factor, but there's room for it, and we will cover that shortly. All right, so continuing with our first patient, 5 years later, she is pregnant with her first child. The pregnancy is at about 36 weeks, and both mom and baby are doing well. She's otherwise healthy, and there's no pregnancy complications to date, but she comes in to talk about questions regarding the delivery plan. A third trimester von Willebrand factor activity has increased from around 20 to the mid 30s. So higher because we know VWF levels rise in pregnancy, but certainly not normal. And she desires an epidural for childbirth if possible. So can she receive an epidural? And the question that was specifically asked is what VWF level should be targeted in order to give someone neuraxial anesthesia? As you can imagine, there's also not a ton of evidence for this. The official recommendation states that in women with von Willebrand disease, for whom neuraxial anesthesia during labor is deemed suitable, the panel suggests targeting a VWF activity level of 50 to 150, which is the normal range, over a level of greater than 150 to allow for neuraxial anesthesia to be administered. And the things that I want to highlight here, individual risk assessment is going to be critical. And this really should be a multidisciplinary discussion with input from the patient, probably most importantly, anesthesia, OB, and hematology. And these discussions are best had prior to the patient's due date. There is a debate about where exactly you want that level to be. We know that during a normal pregnancy, women often have very high levels at the time of delivery, but there's no evidence that we need to target that higher level. So the panel went with the recommendation for targeting the lower levels because a higher level would increase expense and also potentially delay the ability to give the anesthesia while you're trying to achieve a level. And with epidurals, timing is important, meaning that if you need to wait a few hours to do it, you may have lost the window to do the epidural in the first place. So a couple considerations specific to this: higher levels and additional treatment may be required in patients with type 2 or type 3 von Willebrand disease. And it's very important to start these conversations early before delivery so that there is a plan in place to allow the mom to receive the treatment that she wants. In women without von Willebrand disease, as I said, VWF levels at delivery are often greater than 150, but there's little evidence to support treatment to reach this threshold. So the conclusion was that as long as you target something in the normal range, there is no reason to think that administration of neuraxial anesthesia will not be safe for a woman. All right, and then to finish off the pregnancy section, the postpartum hemorrhage area, the panel suggests the use of tranexamic acid over not using it in women with type 1 von Willebrand disease or low VWF levels, and this may also apply to some type 2 and type 3 von Willebrand disease patients in the postpartum period. Tranexamic acid reduces the risk of secondary postpartum hemorrhage. This is well known, and it may reduce the risk of primary postpartum hemorrhage. The risk of adverse events, including thrombosis, were not able to be estimated based on the available studies. They were thought to be small, and this actually caused quite the debate because there's some very strong literature for tranexamic acid in postpartum hemorrhage. And I'm actually going to flip to that graph. This is a Cochrane review looking at all the data for postpartum hemorrhage. The top, outlined in the red box, is the data for early postpartum hemorrhage. The bottom, which is not inside the box, is the data for administering it later in the course. And the data for early administration, less than 3 hours, is very clearly in favor of giving tranexamic acid for early postpartum hemorrhage. And this is for all women, not necessarily even looking at people with bleeding disorders. But going back to the recommendation for just using it for everybody, there just isn't enough evidence, and concern for potential adverse effects left this as a conditional recommendation. And then obviously, since my guesses of the audience, we may be skewed more towards people that have more severe forms of von Willebrand disease. Patients with the more severe forms like type 2 and type 3 may actually need factor concentrate post-delivery. So we certainly don't want to give the impression that all you need to do is give some tranexamic acid and everything would be well controlled. So again, I think discussion with the anesthesia, hematology, OB, and the patient is really important in making sure side effects are minimized and the woman gets the delivery or as close to the delivery that she desires, because we all know things don't always go as planned with children. All right, so We are going to move on to a different case. This is a pediatric case because I'm a pediatrician. A 5-year-old boy who presents with epistaxis and easy bruising. So a workup is done, and this demonstrates that his von Willebrand factor antigen is low at 38, and the von Willebrand factor activity is very low at 11. A multimer panel is done and demonstrates loss of the high molecular weight multimers, and he receives a diagnosis of type 2A von Willebrand disease. So we're not even going through all the diagnosis stuff because I know Robert Sidonio went through that with you a couple weeks ago. So today we're going to skip right to this is his diagnosis. He does not respond well to desmopressin, as many people who have type 2 von Willebrand disease do not, and continues to have bleeding from his nose despite a course of antifibrinolytic therapy. He's seen an ENT physician who has tried cautery, but this didn't help either. Is there a role in this young man for prophylaxis? This is probably actually the area for the management guidelines where there was the most evidence. And the recommendation for prophy came out as in patients with von Willebrand disease with a history of severe and frequent bleeds, the guideline suggests using long-term prophylaxis rather than no prophylaxis. Bleeding symptoms and the need for prophylaxis should be periodically assessed. And although long-term prophylaxis is not as common in von Willebrand disease as it is in hemophilia, there are a substantial number of patients with a severe bleeding phenotype who could benefit from prophylaxis with von Willebrand factor containing concentrates, such as this young man, potentially. There is actually a study. This is the von Willebrand Disease International Prophylaxis Study, headed by Eric Berntorp and Tom Abshire. And they had some very nice inclusion criteria for their study, which are definitely things to think about when you're considering prophylaxis. For joint bleeding, this would be at least 2 apparently spontaneous bleeding episodes in the same joint within 6 months, or 3 or more apparently spontaneous bleeding episodes in different joints within 6 months. For epistaxis, this would be 3 or more episodes within 6 months requiring treatment with VWF concentrate or red blood cell transfusion. For GI bleeding, 2 or more severe GI bleeds associated with either a significant decrease of 2 grams per deciliter in hemoglobin, or requiring red cell transfusion, or requiring VWF concentrate. And then for heavy menstrual bleeding, an elevated menstrual bleeding score, or bleeding requiring treatment with VWF concentrate. And I didn't put a PBAC chart in here, but the PBAC is the Pictorial Bleeding Assessment Chart, which is basically pictures of pads and tampons and how much blood is in them. And you get a certain number of points for how much blood is there. And then you total up all those points. And I think basically just the concept is if you have super heavy periods, that may be something to consider factor concentrate for prophylaxis. We did also propose, there's actually no specific definition of prophylaxis, so all the studies use something a little different. So our proposed definition for the community to consider is prophylaxis for von Willebrand disease, meaning a period of at least 3 to 6 months of treatment, consisting of von Willebrand factor concentrate administered at least once weekly, or for women with heavy menstrual bleeding, use of VWF concentrate administered at least once per menstrual cycle. So this would be anyone that has severe and frequent bleeding would be potentially eligible for prophylaxis to try to control these bleeds. And although the VIP study did kind of put some parameters around this, the way the recommendation is worded, if I go back to this, we were specifically vague in order to allow patients and their physicians to determine amongst themselves if they felt their bleeding history was significant enough that they would like to be on prophylaxis, because there's pros and cons. So I'm going to go back to this now. The impact of bleeding on quality of life is very important. And again, if there's patients listening, obviously you know this, but for the providers, there is a huge impact on quality of life, and that is very significant. Different patients will place different priority on bleeding symptoms. So there may be some children with epistaxis for whom it's not a big issue. There are other children for whom it's hindering their ability to participate in school, participate in sports, and prophylaxis would be more highly valued in those patients. Unfortunately, treatment with factor right now requires IV access and often requires a hospital. So for patients that live near their treatment center, or who have easy veins to access, this may not be as big a consideration. But there are a number of patients who live at a great distance, who don't have any place that they can go, or don't have nice, gigantic veins that are easily accessed. And so, in that case, the waiting may favor not being on prophylaxis depending on their symptoms. Older children and adults can be taught to infuse themselves, which may eliminate the requirement for coming into the hospital. So, that can be helpful in some circumstances, but this is one of the areas that NHF is working on a patient decision aid to help people have discussions with their physicians about, is prophylaxis something that should be considered? And certainly, this is not just for joint bleeds and nosebleeds. It could also be considered for heavy menstrual bleeding. I know Dr. Maggie Ragney has a study right now looking at tranexamic acid, an antifibrinolytic medicine, versus recombinant von Willebrand factor and its effects on periods. So there will hopefully be more data coming out in this area soon. But right now, this is left as a conditional recommendation, meaning the values people place on different aspects, quality of life could be from bleeding, or quality of life could be, I really don't want to be poked to get medicine a couple times a week. There's a lot of room for individual experience here. But since it is a recommendation for prophylaxis, this will hopefully force insurance companies to pay for prophylaxis for affected patients who could really benefit from it. Okay, so we are back to our 5-year-old with von Willebrand disease. He does go on prophylaxis, and his nosebleeds improve on prophylaxis. So much, much better quality of life. But now he's a little bit older and has started snoring. And a thorough evaluation by ENT and pulmonology reveals a diagnosis of sleep apnea. ENT is recommending tonsillectomy. As you recall, this young man does not respond well to desmopressin, so he will require factor concentrate for surgery. How should his factor be dosed for tonsillectomy? So there are some guidelines addressing recommendations for treatment. And I'm going to do the major surgery first and then the minor surgery. So for major surgery, the panel suggests targeting both a factor 8 and von Willebrand factor activity level of greater than 50, so up into the normal range, for at least 3 days following major surgery. This was again a conditional recommendation, mostly based on lack of great evidence. When it is possible to keep both the trough levels, both the factor 8 and von Willebrand factor greater than 50 for at least 3 days, this should be the preferred option. However, the duration of the intervention and specific trough levels can vary depending on the type of surgery. So, for example, neurosurgery, you will probably want to be targeting a higher factor 8 level and for longer. Intracranial hemorrhage, you would be targeting higher levels for a longer period of time. The tonsillectomy, you may be able to get away with a shorter time period of having elevated factor 8 levels. It is going to depend. So there didn't want to be this covers every single type of surgery you might have. The question was more worded around, is there a particular level you should be following? Is it more important to follow factor 8? Or is it more important to follow the von Willebrand factor activity? And we did not have good evidence to support one or the other, although hopefully somebody will tackle that question so we have a better idea of that for future iterations of this. Some other surgical treatment considerations. Patients with type 1 von Willebrand disease may end up receiving treatment with desmopressin. So it doesn't always have to be that you receive factor concentrate for surgery. You just need to get the von Willebrand factor levels up. But patients with type 3 and most type 2 variants will require factor concentrate in order to get a reasonable level to undergo whatever surgical procedure they need. And the fact that there is this requirement for monitoring levels does allow for patient transfer to a hospital capable of monitoring either the VWF or the factor VIII activity during surgery. There is not the absolute requirement to be able to do both, because there are some places where it's easy to get a rapid factor VIII level, but not easy to get a rapid von Willebrand factor level. And we certainly don't want people losing their preferred physicians just because of that. But it was felt that it was important for these surgeries to be taking place somewhere where there was an ability to see what the levels are, especially in case of complications. And then additional treatment, such as antifibrinolytic therapy, may also be very beneficial for these patients. So this is purely a comment on keeping the factor levels up for a few days post-op, but specific recommendations are going to depend on what kind of surgery it is. So after the tonsillectomy, this patient is referred back to hematology for dental clearance. He has one top front baby tooth that just won't fall out. The adult tooth is growing in, but can't fall into place because the baby tooth is blocking it. The dentist wants to extract the baby tooth to prevent misalignment because the other tooth is coming in the wrong way. And the patient's now a little older, nosebleeds have improved, not on prophylaxis, doing really well. How should he be treated for this minor surgery? So we have several considerations in the minor surgery category. So, and I apologize for the wording of these. These are all of the guidelines were done with this PICO format, which looks at the population, the intervention, the comparison group, and then the outcome. So the phrasing is not always the simplest phrasing, but I will try to walk through it slowly and keep the slide up for people to read it on their own. So in patients undergoing minor surgery, the panel suggests increasing the von Willebrand factor level to greater than 50 with either desmopressin or factor concentrate with the addition of tranexamic acid. So factor or desmopressin plus tranexamic acid over raising VWF levels alone. So basically it is probably more beneficial to add tranexamic acid to their increased factor activity than just giving desmopressin or just giving factor. However, individualized therapy plans should consider the bleeding risk for the specific procedure planned. Local hemostatic measures should be used when possible. And this is particularly applicable to oral surgery, where there may be things they can do to control bleeding right away. And some of the factors that went into this discussion, while combination therapy may pose the highest risk of side effects, it was thought that it was also more likely to decrease bleeding risks, and the combination of factor plus an antifibrinolytic treatment may be synergistic, and that would be more important in controlling bleeding than either one or the other alone. This is for the general von Willebrand disease population. So if we look at just the population of patients that have type 1 von Willebrand disease with a minor reduction in levels, the former low VWF group, and if you remember from diagnosis, the guidelines suggest that as long as you have VWF less than 50 and bleeding symptoms, anybody with levels in that 30 to 50 range can receive a diagnosis of type 1 von Willebrand disease. So this recommendation is specific to that group of patients, the type 1, but the levels are between 30 and 50. In that group, the panel suggests giving tranexamic acid alone over increasing the VWF level to greater than 50. And that was also a conditional recommendation, again, based on not so much evidence for what should be done in this situation. The thinking here is that the expense and the side effects of desmopressin make antifibrinolytic therapy both lower cost and lower risk in this setting. and the panel placed a high value on avoiding the burden of extra therapy in this patient population given the lower risk of bleeding, which is not to say that these patients don't bleed because they're getting a diagnosis of von Willebrand disease because they do have bleeding, just that they are less likely to have a major bleed with these surgeries if they don't receive both treatments. And so the thinking was giving just the tranexamic acid would be the most cost effective and have the best quality of life. Most places, tranexamic acid is extremely cheap. And even in the United States, a course of desmopressin is at least 3 times the price of a course of tranexamic acid. All right, I'm going to do a semi-adult case, 18-year-old with type 1 von Willebrand disease. So this young man, we are presuming, was seen by hematology at an outside institution somewhere and received a diagnosis of von Willebrand disease. He comes to your clinic because he's continuing to have easy bruising and nosebleeds. The medical records from that visit have been lost. They've disappeared somewhere in the transition to electronic medical records, but the patient knows that it's type 1 von Willebrand disease. And of course, the main reason he's in clinic is because he's requiring extraction of 4 impacted wisdom teeth in the near future. The oral surgeon is aware of this distant diagnosis of type 1, and the patient needs clearance from the oral surgeon because of the history. So, should you prescribe desmopressin for this patient? He has a pretty good idea that it's type 1, so he should respond. Can you give desmopressin in this situation? Well, what the guidelines state is that in patients for whom desmopressin is a valid treatment option, which is primarily type 1, nobody is suggesting you give desmopressin to patients with type 3 von Willebrand disease. The panel suggests performing a trial of desmopressin and treating based on the results over not performing a trial and treating with antifibrinolytics or factor. Again, a conditional recommendation, very low certainty in the evidence surrounding this. In these patients, the panel also suggests against treating with desmopressin without desmopressin trial results. So basically saying in these patients, except for a specific group we'll talk about, it's more important to have the trial results. And the trial should be performed and then treat based on those results rather than just guessing at a treatment. However, this recommendation does primarily apply to those with VWF levels less than 30. Some centers would consider that patients with levels of greater than 30, so in that 30 to 50 group, those patients will respond to desmopressin and therefore in some cases will treat without doing a formal desmopressin trial. However, in those patients, the response to desmopressin should still be documented, even if you're doing that documentation at the time of surgery for future reference. So in case they need more major surgery at a later date, you will have that data. And this is some of the data that comes from Ireland, actually, out of the LOVIC cohort, low von Willebrand factor. These are patients that all had VWF levels initially in the 30 to 50 range. And this is desmopressin trial results. In the paper, they were looking at a bunch of other things, but I just want to show you that everyone in this cohort had levels that went to well above 50 with desmopressin. Some of them went to well above 100, and a few patients actually had levels go above 200. But everyone's level went up above 50 in this cohort. However, I think that many of us have our anecdotal cases where we have patients that did not go up above 50 or did not have a great response to desmopressin. So I don't have a good answer for what to do. Certainly, it's a conditional recommendation. It's not saying you have to follow this if you have individual circumstances. It does make me more likely if it's a very minor procedure and they haven't had a desmopressin trial to consider doing the trial along with the procedure. Desmopressin trials are extraordinarily inconvenient to patients. You get all of the side effects of the desmopressin with none of the benefit of it actually stopping a significant bleed, and you have to get poked multiple times to get levels. So that is also a consideration in the quality of life for patients that are living with von Willebrand disease. But on the other hand, if they're undergoing major surgery and you think desmopressin is a reasonable treatment option, there are probably fairly strong reasons that you would want to document what their response is beforehand. All right, on to our last case and last recommendation. I am coming out of my comfort zone here. I do not see adults usually. This is a 70-year-old female with a history of von Willebrand disease. And that history is a long-standing history of well-documented type 1 von Willebrand disease. She has a history of heavy menstrual bleeding and also still continues to experience easy bruising, but has a recent diagnosis of heart disease now requiring aspirin therapy. Her cardiologist has not prescribed it because aspirin is listed as an allergy in her medical record. And both the patient and her PMD are very worried about aspirin use given this history of von Willebrand disease. Should she receive aspirin therapy? So here's the recommendation around anti-thrombotic therapy for patients with von Willebrand disease. In patients with von Willebrand disease and cardiovascular disease who require treatment with antiplatelet agents or anticoagulant therapy, the panel suggests giving the necessary antiplatelet or anticoagulation therapy over no treatment. We don't want to deny the appropriate treatment for heart disease to people that actually need it. Some consideration, though, should be done regarding how this is given. This is another area where an individualized discussion of risks and benefits is important and should occur with the patient, the cardiovascular medicine specialist, and the hematologist, and possibly the primary physician as well. Periodic reassessment of bleeding risk while they're on this medication is important. And some patients may actually benefit from prophylaxis with a von Willebrand factor concentrate to prevent bleeding while on anti-thrombotic therapy. And that seems kind of counterproductive, but these treatments all do different things. And when you have a complex situation, like somebody who has bad cardiovascular disease, where they need to be on an antiplatelet agent, but they also have a significant risk of bleeding, that may be a valid option. But another area where these multidisciplinary discussions should occur, and they absolutely need to include the patient. And I've tried to make sure the patient is actually listed first in all of these because that is critical to the nature of these discussions. And hopefully this will be another one where NHF is able to work on a patient decision aid. As we have an aging population, this becomes more and more of an issue for our patients. All right, so to quickly summarize, because I want to make sure there's lots of time for questions, there are new guidelines. They exist finally regarding von Willebrand disease management, and a special shout out to our amazing panel. But there remains a lack of evidence in many areas. So there is a lot of room for patient preferences in treatment and how it's administered. So not saying that you shouldn't be treated before a surgery, but there may be options in how that is done. We're not saying you have to be treated for heavy menstrual bleeding, but there are now a ton of different options and some evidence for the different options and how it should be administered and what those options might be. And quality of life is an important treatment consideration. So generally, nosebleeds are not fatal. But if they're affecting somebody's quality of life, that is a very valid reason to consider putting somebody on with von Willebrand disease on prophylaxis to try and improve that. All right. I want to thank ASH, ISTH, NHF, and WFH for their amazing work supporting the guidelines, my outstanding co-chairs, Nathan Cannell, Paula James, and Reem Mustafa, and the entire panel group for their really, truly inspiring efforts. And then the NHF staff for all their hard work and the many ongoing efforts to translate these out to patients and providers and make them more useful in the future. So thank you, and I will be happy to answer all the questions that have been popping up in the chat.
Great. Thanks so much, Dr. Flood. We appreciate the informative information or the information that you provided. And we do have several questions that come in. And I will start as I trying to share a slide here. I'll start with our first one. You may or may not have seen this one coming, but the question is, why was Stimate recalled and what should people use instead of Stimate?
Yeah, so I do not work for that pharmaceutical company. My understanding is there was a concern that the vials had both too much desmopressin and too much of a potential contaminant, something in the manufacturing process, and therefore they were recalled. And my vague conception is it's something to do with the bottling process, which is why this is taking so long to fix. Dr. Valentino, I know, is on. So if he has any better information than I do and wants to jump in before I address the how to replace it, feel free.
Thanks, Dr. Flood. So I think the challenge with the vials was that the stopper allowed evaporation of the liquid part of the desmopressin. And as the liquid evaporated, it resulted in a higher concentration of the desmopressin in the vials, which was deemed to be well, first of all, it was out of specifications for their manufacturing process and deemed to be potentially dangerous for patients.
Thank you. So I can tell you what we've been doing, which is a lot of antifibrinolytics and then some IV desmopressin. So the IV form is still available. It's basically all of the inconvenience of desmopressin with a little added besides. And you don't even get the nice, easy intranasal format. But there are certainly surgical procedures that we don't feel comfortable in certain patients not giving something for. And some patients with type 1 that have a fantastic response to desmopressin, that's still the preferred option over factor. I think the two big populations that we're struggling with are the nosebleeds and the heavy menstrual bleeding. Uh, Nosebleeds, again, we do a lot of Amicar in kids, but antifibrinolytics, Amicar or tranexamic acid. We've been doing a lot of other supportive measures for those people, and occasionally bringing people in for a dose of IV desmopressin. For the heavy menstrual bleeding, we've been doing tranexamic acid for the women that loved their Stimate. We've done factor for some of them. We've done desmopressin for one or two, but usually the decision tree there is go back to OB and discuss hormones, discuss Lysata, which is tranexamic acid, and less of the jumping to an IV product. But if anybody else has great suggestions, Wisconsin in the winter is nosebleed city. And we've had a lot of kids that have really utilized that intranasal Stimate. So I'm always open to suggestions too. The IV form is still available, just to make that clear. So for surgical settings, it's not quite as difficult, except for all the wisdom teeth extractions that don't take place at the hospital. They take place at an outside setting where we were using a lot of Stimate. So it is a problem for the community for sure.
Thanks, Dr. Flood. The next question that comes in, are there any issues expected with getting insurances to pay for prophylaxis with patients with VWD?
Yeah, so the hope was that with the recommendation coming out in support of prophylaxis, and there are people at NHF actively advocating with insurance companies that we will be able to, I don't want to, this is a recorded line, so I don't want to say force insurance companies to pay, but there is evidence to suggest that prophylaxis is important and therefore is something that should be covered. And that is the goal, that insurance companies will not be able to deny approval for prophylaxis for von Willebrand disease just because it's not as common as has been used in the hemophilia setting. First of all, there's not enough evidence. And second of all, for differences in quality of life, we didn't want to make it everybody with this amount of bleeding needs to be on prophylaxis. But the hope is that with the recommendation in support of it, that insurance companies will need to cover it for people.
Great. Thanks, Dr. Flood. The next question that comes in.
Fred, I might just add to that.
Yes, sir, please.
That if people in the community do experience any challenges with payment for prophylaxis that's recommended and prescribed by your clinician, the NHF would like to hear about those episodes. I think it's really important that we continue to advocate for the implementation of these guidelines and any barriers to implementation of the guidelines were important for us to understand. So we want to hear about those issues if they arise.
Yeah, that's a great point, Len. Thank you for interjecting there.
Thank you. Because that's also critical, that financial quality of life is an important aspect. And if you can't get this covered, it's a huge cost to patients. And so we need for the insurance companies to cover the pro fee for people that need it.
Yeah, we actually have some questions that came in about health equities and inequities, which we'll definitely get to. But the next one comes in for dental extractions. What dosage and for how long are you using TXA? Also, do you have any input on crushing TXA and mixing it with water to create a mouth rinse?
I haven't done that with tranexamic acid, but our pharmacy will do for Amicar, we'll do the injectable form and use that as a mouthwash. So absolutely. And for dental extractions, it's super easy because all they have to do is swish it around their mouth and spit it out. You don't even need to get the patient, because I work with a lot of kids, to swallow the medicine. The dosage and length of treatment kind of depends on what it is. If it's a baby tooth, we'll do a couple days. If it's a grown-up tooth, we'll do a week. If it's wisdom teeth, we'll do 7 to 14 days, depending on how long it takes to heal. And I think it just also depends on how extensive the surgery is. If you have an impacted wisdom tooth, that's going to be a lot different than the example case where you're just extracting a stubborn baby tooth. We usually do 3 times a day. I know Amicar is officially prescribed as 4 times a day, but at least in pediatrics, nobody takes anything 4 times a day. So we just usually say TID for both of them and standard doses.
Great. Thanks, Dr. Flood. The next question that comes in is, since the guidelines are for international use, how do you communicate the amount of bleeding in countries where period poverty or inequities is hugely present and tampons and use?
So I should have said that the guidelines were initially intended for high resource settings. So the hope is that ASH and the other supporting institutions will come out with a version for lower resourced settings, but this was really meant as the first world guideline. I think we also need to acknowledge that there's areas of our own country where some of these things are not possible. And certainly internationally, there's plenty of areas that might be considered a high resource setting where this is an issue. Potentially, again, across here, our inner city Milwaukee, for example, things aren't necessarily always readily available. So I think then it's just careful questioning. And most of the time you can get a CBC. So if somebody has iron deficiency due to their heavy menstrual bleeding, I think that's pretty supportive that this is significantly affecting them. And then, discussion with the patient about exactly what the side effects are and what the effects are on their quality of life. The problem is when you're in an under-resourced area with an under-resourced family, the options may be limited, but tranexamic acid is extremely cheap and tends to be a little better received in some communities than hormone therapy. So I work in pediatrics, and a lot of families have strong feelings about not giving an adolescent girl hormones, but tranexamic acid is cheap and easy, and you just have to take it during your period. Factor can be a little harder to administer in those settings. And I really appreciate the question for bringing out the fact that there are tons of health inequities. And as physicians, we have a tendency to assume that all these things are available to all our patients, but they may not be. Even just getting to the pharmacy to pick up a prescription can be an issue for some families.
Yeah, that's a great point. The next question comes in through the Q&A from Mike, and he asks, have the guidelines considered if there is an age above which desmopressin should not be used?
That is a good question, and thank you for listening, because sometimes I feel like you should be giving these talks, Dr. Macris, but no, it was left intentionally vague because we didn't want to declare a universal cutoff, but it's important, and in the subtext, it is extremely important to consider what the comorbidities are, because there may actually be younger adults with comorbidities that shouldn't be receiving desmopressin, and there may be some healthy, slightly older, and the older I get, I don't want to name any specific cutoffs for old, but if you have somebody that's very healthy and has a healthy heart, it could be considered at a higher age, but we're also seeing so much heart disease in younger people that it's really important to consider side effects when you're treating adults with potential cardiac conditions.
Great. Thanks, Dr. Flood. The next question is, obviously healthcare providers within this community will be informed about these recommendations, but how do healthcare providers outside of the HTC network learn about these?
Yeah. So NHF actually is spearheading some efforts to get this out to other communities. One is through the patients, actually. I think empowering patients to have this knowledge and to be able to talk about it with their physicians, because unfortunately, we're never going to be able to reach the providers that aren't willing to hear. But there is intended to be targeted outreach to, we have GYN on the panel who is helping, and then NHF is also helping to get this into the OB/GYN groups, to get this out to primary care physicians, to get this out to ENTs, for example, since several of my case examples involved ENTs. I know a lot of our local area von Willebrand disease is picked up by our adolescent medicine specialists from girls that present with heavy menstrual bleeding. So I think the OB/GYN area is critically important, but you're right, it's kind of preaching to the choir when we talk about it with some of the HTC groups, and the people that really need to hear are the people that are outside this little area. But NHF, and I don't know if Len wants to mention anything specifically, they have a number of people working on this behind the scenes.
Okay. Feel free to chime in, Len, if you want the opportunity.
Yeah.
If not, go ahead.
No, I think Veronica covered it very well. So I don't really have anything else to add.
Great. There's a couple more questions that have come in, Dr. Flood. I know we only have a few minutes here, but
No, I'm good.
Great. This one is along the same lines of the last question, a good question nonetheless. How can patients be empowered to advocate for their best care when they don't receive their hematology care at an HTC or have to communicate with a non-hematology provider like an OB/GYN?
Yeah. So NHF is actually actively working with some really, I don't know if I'm allowed to name Lena specifically, but some really wonderful people who are working on some patient decision tools and some patient support tools that will allow you to have some patients to have something in writing that can help open that discussion with physicians. I think that is a great question, though, and we've actually been doing a lot of discussions about unconscious bias and how to have these conversations. And patient-physician relationships is one of those difficult areas where if you have a relationship where the physician is a little more distant, even if you have a piece of paper in your hand, it's going to be it takes a lot of courage to open up those conversations and say, look, I'm not sure I'm receiving the right treatment. And look, here's some evidence that maybe I should be on prophylaxis, or here's some evidence that here's what I could be on for my periods. Can we discuss it? So I think NHF has some areas of support that can help you out. Maybe we can do some mock conversations. I don't know. It's very tricky. I think if you have a great doctor, then you might not even need these aids. You can just go to your doctor and say, hey, my periods are bad and what can I do about it? If you're not in as good a place with your physician, it's going to be much harder. And I acknowledge that. But hopefully some of these decision tools and support tools will be helpful in initiating those conversations. You can also print out the guidelines or, put in whatever your electronic medical record communication thing is. Could you please take a look at these? But again, that might require more courage because these are easy for me to say, and I'm not sure I would ever do it in person to one of my physicians. And I'm a doctor. I don't know if I could have the courage to do that, but we have an amazing patient population at NHF, and I bet there's support groups from other patients, particularly the ones that worked on this guideline, that are really good at speaking up for what they need. And maybe we should have them do a seminar on how they advocate, what their best practices are.
Thanks, Dr. Flood. I think the other point that I'll make is it's important to become as educated as possible and knowledgeable. So attending events like today's webinar is really important. There's going to be quite a bit of presentation at the Virtual Bleeding Disorders Conference in August. And I think that's a great opportunity for the community to get more information and more education around these guidelines and how to become more engaged and empowered so that you can have those types of discussions with your clinicians. So I would strongly encourage everybody to participate in the Virtual Bleeding Disorders Conference in August.
Yeah, very much agreed. And we're very proud of Lena and the entire education team and the work that they are doing. So you can call them out at any time, Dr. Flood.
All right.
I think we have one more question that came in here, and it is the recommendations call for prophylaxis. How will this be addressed in developing countries where this might not be accessible?
Yeah. So this is intended for more resourced settings where this is something, and again, there are parts of the United States where that probably isn't practical either. So the recommendation is still conditional. It does not mean you're committing malpractice if you don't put somebody on prophy. I think we're just going to need to get creative, and we clearly need better healthcare delivery. We have a home health nurse here that goes out to people's houses. Unfortunately, that only helps if you're within a certain radius of our treatment center. And there's a lot of big states, especially out west, where that wouldn't be possible. It's going to be tricky. I think as we look at implementing this in other areas, I know the hemophilia community has done some great things with factor donation and getting it to areas in need, but without good infrastructure, it is really tricky. And particularly when you're dealing with IV medications that you can't just, ship a pill somewhere, it's tricky. It's a real problem.
Great. Well, thank you so much, Dr. Flood. We'd like to just thank you for taking the time to join us this afternoon. We appreciate your time and your expertise, and thanks for being here and all the work that you've done.
I'm always happy to. And if people have questions that didn't get answered, please feel free to hit me up afterwards.
Great. Thank you. And please note that this recorded webinar will be available on Friday, May 28th at hemophilia.org under the events tab with all of our other archived webinars. Also available in the events tab is our upcoming schedule for our weekly webinar series. Thanks again, Dr. Flood, for joining us. We appreciate it. Take care, and everyone.
Thanks everyone for listening.
Thank you.
Have a good day.
Thank you, Dr. Flood. Have a great day. Thanks, everybody.
Thank you.